Hello, friends. Welcome to AORA Block of the Month. I am Dr. Shailesh Mulgaonkar from Mumbai. I am a freelancer attached to Breach Candy Hospital, Holy Family Hospital, Raheja Hospital, Surya Hospital. Today, I'm going to talk about PNS guided femoral and obturator nerve blocks. Now, let us start with the anatomy of the lumbar plexus. As you all know, lumbar plexus is formed by the ventral rami of L1, L2, L3, and L4, and contributions from T12, which is prefix, and L5, which is postfix. And it is situated in the posterior part of the psoas muscle. Now, lower limb is mainly supplied by four nerves. The lumbar plexus gives rise to femoral, obturator, and lateral femoral cutaneous. And the sacral plexus gives rise to the sciatic nerve. Now, let us come to the lumbar plexus, which gives rise to the femoral nerve, obturator, and lateral femoral cutaneous nerve of thigh. So, when you come to the femoral nerve, we'll first talk about the femoral nerve. It is the largest branch of the lumbar plexus. It is derived from the posterior divisions of the ventral rami of L2, L3, and L4 nerve roots. It emerges from the lateral border of the psoas muscle, and it is deep to the fascia iliaca, and it emerges behind the inguinal ligament into the femoral triangle, and then it divides into anterior and posterior branches about 3 to 4 centimeters below the inguinal ligament. So if you see this picture, at the level of the inguinal ligament, the femoral nerve is quite deep inside, whereas below the inguinal ligament, at the level of the inguinal crease, it is much more superficial, it is much thicker, and even the anatomy is much more predictable. That's why you have to give a femoral block at a lower level, not at the level of the inguinal ligament. Now let us come to the anatomy of the femoral nerve. So femoral nerve, as soon as it comes below the inguinal ligament, about 3 centimeters below, it divides into the posterior division and the anterior division. The anterior division supplies the sartorius muscle, the motor branches to the sartorius muscle, and then intermedial cutaneous nerve of thigh, a middle cutaneous nerve of thigh, whereas the posterior division supplies the hip joint as well as the knee joint and the quadriceps, the rectus femoris, the vastus lateralis, vasta intermedialis, vastus medialis. And then it comes down and as a saphenous nerve in the adductor canal. So all this is only the cutaneous supply. All the motor branches are given at a higher level. That's why when you give an adductor canal block, the quadriceps weakness is spared. Then it comes down at the level of the foot. So for the ankle block, you give a saphenous nerve block here. Now, just keep in mind that because the main purpose of the femoral nerve block is the hip joint pain and the knee joint pain. So you have to block the posterior division of the femoral nerve, not the anterior division. When we are using a nerve stimulator, just keep this in mind. Now, these are the dermatomes, the myotomes, and the osteotomes of the femoral nerve. Now, what are the indications for the femoral nerve blocks? The surgeries involving the femur, the patella, the knee, like arthroscopies, quadriceps tendon, supplementary analgesia for the hip and knee surgeries, that is on arrival blocks, especially hip fractures. As soon as they arrive, it's so painful. As soon as you give a femoral nerve block, they're very comfortable. Then, if the patient comes for hip replacement surgeries, you want to make the patient sit for spinal or epidural. It is so painful, but once you give the femoral nerve block, within 5 minutes, the patient will be able to sit up and you can give a spinal or epidural. Now, they are also as a supplement for sciatic nerve blocks for below knee surgery. So, below knee, everything is supplied by the sciatic and its branches, the tibial and the common peroneal, except the medial portion which is a saphenous nerve, which is a cutaneous branch, which is a continuation of the posterior branch of the femoral nerve. Now, what are the contraindications? Standard contraindications are patient refusal, allergy to local anesthetic agents, local infection, and pre-existing neuropathy. So you have to take a proper history before giving the femoral nerve. Now, these are the standard equipments required for all the standard nerve blocks. Sterile gloves, towels, gauze, sterile solutions. You have to take proper aseptic precautions for all the nerve blocks. Then marking pen, then 2 ml syringe for local infiltration where you're going to poke the patient, then 10 ml syringe for main anesthetic agents where we are going to inject. 50 millimeter needle is more than enough for a femoral nerve block because it's a very superficial nerve. Even in obese patients, within 1 to 2 centimeters, when you press the thumb down, the nerve becomes superficial, and within 1 to 2 centimeters, you can get a femoral nerve. Then peripheral nerve stimulator and surface electrode. The injection pressure monitor, if it is available, that is ideal to prevent intraneural injections. Now, continuous technique, I usually try to avoid for femoral and obturator nerve blocks because the area is little unhygienic, the chances of infection are more. Now, what are the local anesthetic doses? For surgical anesthesia, you use bupivacaine 0.5% or ropivacaine 0.5%, levobupivacaine 0.5%, and maximum 10 to 15 ml is more than enough because it's a very superficial needle. Then again, for analgesia, the lower concentrations 0.25% bupivacaine, 0.2% ropivacaine, levobupivacaine 0.25%. Then for an infusion pump, for a continuous block, I will not mention because I try to avoid continuous block in these patients. Now, what are the different approaches of the femoral nerve block? So, as I told you, at the level of the femoral crease is most important and most common. Now, fascia iliaca block, when a PNS is not available, when ultrasound is not available, you can give a femoral nerve block. It is also called as a fascia iliaca block. I will come to that later on. Now, suprainguinal fascia iliaca block and pericapsular nerve group block, that is a pen block. These two blocks are only with ultrasound, so I am not going to mention all those details. Now, for any block, stop before you block and just confirm the patient's identity, the correct side, the correct indication for the block, the drug choice and dosage you have to calculate, proper equipment, everything has to be kept ready. Intralipid 20% is most important to prevent local anesthesia systemic toxicity. And if injection pressure monitor is available, nothing like it, the pressure while injecting should not increase to more than 15 to 20 psi. Take a proper informed consent of the patient, and all monitoring has to be done to prevent intraoperative complications. Now, all lower limb blocks, I usually start with about 1.5 milliampere current. Frequency, I usually use 2 hertz because if you use 1 hertz, that means 1 current per second. And if you're using that low frequency and if you're poking the patient and entering very fast, it can, by the time the next current comes in, you can either be intraneural or you can go away from the nerve. So 2 hertz is more than enough. Pulse duration 0.1 millisecond. Most of the older versions of nerve stimulator have a fixed pulse duration, also called as a pulse width of 0.1 milliseconds. Accept motor response. Now, this is the most important step which you have to follow. Accept motor response at 0.4 to 0.5 milliamperes, end motor response. Once you get that end motor response, reduce the current to 0.3 milliamperes. At less than 0.3, the end motor response should disappear. Again, to come back to 0.5 milliamperes, and again, the end motor response should come back. So, this proves that you are not too far away from the nerve, neither you are intraneural. And always keep on aspirating and injecting to prevent intravascular injections. Always, as soon as you inject 1 ml, the end motor response should stop. It is called as a Raj sign. Previously, they used to think that when you inject the local anesthetic drug, the nerve gets pushed away, and that's why the end motor response stops. But it is proven that when you're injecting local anesthetic or even normal saline instead of local anesthetic, the end motor response stops because these are electrically conductive solutions. So the current gets diluted, which you're using. But if you're using dextrose, 5% dextrose or distilled water and injecting the same volume, the end motor response keeps on going. Again, there should be no resistance while injecting, and patient should not get pain while injecting. That's why, as far as possible, don't sedate the patient if the patient is cooperative. Don't give general anesthesia to the patient and then give the blood. Now, this is a standard position which people use for femoral nerve block. The only thing is you require an assistant to pull the abdomen away, especially obese patients. You have to pull the tummy, so you require an assistant. So I usually don't use this position. So this thing is I press the thumb, I push the tummy with my fist. I press the thumb on the femoral artery. After that, I will show in the next slide. I just tilt my thumb externally to confirm that on this part of my thumb, I cannot feel the pulsation. That means I am exactly on the femoral artery. So that when I go 1 centimeter lateral to it, I will not puncture the artery. It's vein, artery, and nerve. So if I keep my thumb here more medially, I can still feel the pulsations. But if I go 1 centimeter lateral, then I can puncture the artery. I'll show you in the next slide. Now inject local anesthesia very superficially here before poking the patient. If you inject little deep and if you inject little larger volume, you may not get the end motor response. And angle should be about 45 to 60 degrees. So this is the patient. This is the right hip. Head end is on this side. Foot end is on this side. And what I do is I usually push the tummy with my fist and then I press the thumb so that the nerve becomes much more superficial and I tilt the thumb so that I don't feel the pulsations here. Suppose my thumb is here, I can still feel the pulsations. Okay. And then if I go 1 centimeter lateral to it, I can puncture the artery directly. So I always tilt and confirm there is no sensation on this side of my thumb or no arterial pulsations. Right. So this is the femoral nerve block. As I told you, don't accept the twitches of the sartorial muscles. The sartorius is supplied to the anterior division, which does not supply the hip and the knee joint. So the main purpose is not served. So I'm pushing the needle. These are the sartorial muscle twitches. So then I go more posterior and more lateral till I get the quadriceps twitches. So this is the ideal end motor response for the femoral block. And then again, as I told you, reduce the current to 0.5, only then inject. So you should get this proper end motor response. Dancing patella, it is called. Now, fascia iliaca block, when PNS is not available, when ultrasound machine is not available, fascia iliaca block is ideal. So you take a needle which is blunt so that you can feel the dual pop, the fascia lata as well as the fascia iliaca. Once you enter the fascia iliaca and you inject, the drug goes towards the femoral nerve and it blocks the femoral nerve. So now the landmarks are anterior superior iliac spine and the pubic tubercle. Divide into medial 2/3 and lateral 1/3. Go 1 centimeter below this junction and then go perpendicular to the skin. The first pop is fascia lata, the second pop is fascia iliaca. Then keep on aspirating and injecting. So if you see this video, I'm using the epidural needle, which is blunt, 18 gauge epidural needle. This is the first pop. Then watch carefully. The second pop. Remove the stillet, attach a syringe, and 15 to 20 ml, I'll keep on aspirating and injecting. You can take a smaller syringe, 10 ml syringe, so that there is no resistance while injecting. Okay, so keep on aspirating and injecting. And most important is at the end of the thing, if you get a backflow, that means you are definitely in the facial plane. So this is a fascia iliaca. Now, how do you evaluate the success of the block? The sensory block by cold or pinprick test on the anterior and the middle aspect of the thigh, which is the sensory innervation of the femoral nerve. And for motor block, ask the patient to extend the knee. You can just ask him to lift the leg. That is enough. Now let us come to the saphenous nerve block. So if the femoral nerve comes down into the adductor canal, and here you can give a adductor canal block, especially for knee replacement surgeries. You can also just infiltrate the medial femoral condyle as an accessory block to the popliteal sciatic nerve for any surgery below the knee, or even infiltration around the medial tibial condyle. Or for any ankle surgery, you can give an ankle block. So 5 nerves are to be blocked, 2 deep and 3 superficial. Deep peroneal, posterior tibia are the deep nerves, and superficial peroneal, sural, and the saphenous are the superficial nerves. So saphenous nerve superficial is for the ankle. Now let us come to the adductor canal. It is also called the subsartorial canal or the Hunter's canal. Now what are the contents in the adductor canal? The femoral artery, the femoral vein, and the saphenous nerve and nerve to vastus medialis. Now many times ultrasound is not available, and I have given quite a few times this adductor canal block with a peripheral nerve stimulator, where you have to stimulate the nerve to vastus medialis. So you have to go between the sartorius, this is sartorius which is cut, and the vastus medialis. In that groove, you have to go. You have to go, this is the patella, you have to go 4 finger breadths above the patella and medially. And you have to use a longer needle, at least 8 to 10 centimeter needle, and go perpendicular. First infiltrate little local anesthesia and then go deep inside. Now, if you see this, actually my assistant had kept a little higher current, so the nerve to vastus medialis is getting stimulated. So this is the end motor response. Now you have to keep on reducing the current, as I told you, to 0.5. Keep on reducing the current to 0.5. The end motor response should continue. The twitches of the vastus medialis should continue. At 0.5, they are continuing. Then reduce to 0.2. The end motor response should disappear. You can see this at 0.21, it is gone. Then again increase to 0.5. Again at 0.5, comes back. That means you are definitely not intraneural and definitely not far away from the nerve. And then you inject 1 cc and the end motor response will stop. So that is called as a Raj sign. So this is the adductor canal block with a nerve stimulator, which I don't use regularly. Only thing is, rarely when the ultrasound is not available, I give this block. Now, as I told you, just infiltration at the level of the tibial tuberosity. This is a supplement to analgesia for the sciatic nerve block, obturator sciatic, for any surgery below the knee. And this is the ankle block, just infiltration from the medial malleolus up to the extensor hallucis longus, just superficial infiltration for the saphenous. Now let us come to the obturator nerve block. Now the obturator nerve is derived from the anterior divisions of the ventral primary rami of L2, L3 and L4. It runs within the psoas muscle till the sacroiliac joint, and then it traverses towards the obturator foramen, and finally it divides into anterior and the posterior branch. So obturator nerve also supplies to the hip as well as the knee joint. Now anterior division supplies the adductor longus, adductor brevis, gracilis, and the hip joint. The posterior division supplies the obturator externus, obturator magnus, adductor brevis, and the knee joint. Now, these are the osteotomes, the myotomes, and the dermatomes of the obturator nerve. Now, what are the indications for the obturator nerve? For the anesthetist, the most important is TUR bladder tumor, even after spinal anesthesia, because spinal anesthesia it's a central neuraxial block. The obturator nerve traverses just outside the urinary bladder. And if there's a tumor on one side of the bladder, whichever side it is, when they do a transurethral resection and they use a higher current cautery, so suddenly the obturator nerve can get stimulated directly by the current, and patient is in lithotomy, and suddenly they get an obturator reflex, sudden jerky movement of the adductors, and by mistake the bladder can get ruptured. That's why after spinal, whichever side the tumor is, you have to give that side obturator nerve block. Second indication is treatment of adductor spasms associated with hemiplegia or paraplegia, or as an adjunct to femoral nerve block for hip and knee joint pain. So any surgery for the hip, if you want to do only under a nerve block, then you have to block all the four nerves, the femoral, the obturator, lateral femoral cutaneous, as well as the sciatic nerve. Now, there are different approaches for the obturator nerve block. So the main landmarks are the pubic tubercle, the superior pubic ramus, and the inferior pubic ramus. So this is the pubic tubercle. So draw a line laterally for about 2 centimeters and caudally 2 centimeters. This is the point of insertion. Go first perpendicular to the skin. You might hit the inferior pubic ramus, and then just withdraw the needle slightly and go more laterally where it comes out from the superior pubic ramus. But don't go too deep because there are multiple vessels inside. I will come to that later on. So here I am giving obturator nerve block, and the end motor response to be accepted is the adductor twitches. Okay, so just slightly externally rotate the thigh, and it's not a very deep block, but in obese patients, we require at least a 8 millimeter or a 8 centimeter or a 10 centimeter needle. And this is the end motor response. Sensory testing in obturator nerve block is challenging because the dermatomes, the supply is little erratic. Adductor motor weakness has to be there. Now, what are the complications of obturator nerve block? So, don't insert the needle too deep because if it goes beyond the obturator nerve, there are multiple vessels there, multiple organs there. Obturator vessels are too close. Obturator neuropathy, if you can damage the obturator nerve, the chances of infection are very high because of this location. And impaired early ambulation. You have to inform the patient properly that while walking, you might get adductor weakness. So be a little careful while walking. So now what is the take-home message? Don't give up peripheral nerve stimulator even though you are a master in ultrasound. Be greedy and use both. Thank you all, and thanks to the AORA team for giving me this opportunity. Thanks a lot.